This interview was recorded at the 2012 SVS annual meeting in Washington, D.C.
Recently, the Society for Vascular Surgery decided to put together a video archive of the history of vascular surgery by interviewing a number of the contributors to it and putting the information together so that others could see this on a website and have access to some of the interesting and important history of vascular surgery that is documented by the conversations with these individuals. And today we have Pat Clagett with us, who spent much of his professional career at Texas Southwestern and is an important leader in vascular surgery and also an important clinician, having contributed in both areas in many ways. And Pat, you grew up in the Washington area.
I did. About 15 minutes from this site, as a matter of fact. And my parents were, my father was a lawyer, but he also was a tobacco farmer. Interestingly enough, we had a tobacco farm. A bit of a conflict of interest, but, but that was the case. And I grew up here in rural southern Maryland, and we had a fine time.
You went, so you went to high school in this area?
I did. I went to Severn School, which was on the Severn River. That was a prep school for the Naval Academy, but I did not go to the Naval Academy, obviously. Ended up at the University of Virginia and was there for 4 years in college as an English major, and then went to medical school at UVA.
I suppose that English major did you well in your career as a academic writer, as one of your sidelines of work.
Absolutely. It's interesting to me that you get really very smart medical students, residents, fellows that are just brilliant, but they can't conceptualize a paragraph, and they can't write, a leading sentence and then fill in the paragraph, and their thoughts are all over the place. I think having to write makes you organize your thought processes so that when you put something down on paper, it's meaningful. And you try to say as much as you can in as few words as possible, and that's another art.
Mm-hmm. And then when you graduated, the Vietnam War was taking place, and there was the consideration of a draft.
Correct. And they had the Berry Plan, which was a plan whereby you could defer your entrance into the military so that you would not be drafted right out of medical school. And the Berry Plan would allow you to finish your training, which in my case took 7 years, with 2 years for research. And I was in the Berry Plan, and when it came time to enter the military, the Vietnam War was long gone. Mm-hmm. But nevertheless, I had the obligation and had to fulfill the obligation, which was another great experience. Mm-hmm. I ended up at Walter Reed, the Walter Reed Army Institute of Research, where there was a 3-year obligation. Most of the obligations were for 2 years, but this was 3 years because it was sort of a cushy job with research, and that was a really good experience.
Mm-hmm. So you did your residency at the University of Michigan.
Correct.
And you had the opportunity to go and do some research during that time.
Yes.
How did you do that? I mean, you had 2 years in Boston.
Well, I think it was a nationally funded program, a grant to the University of Michigan for the Department of Surgery to outsource some of their residents for research for 2 years, and I forget whether it was the NIH or the VA, one of those institutions funded this. And I did 2 years of research in Boston with Ed Salzman, who was a wonderful surgeon scientist. Ed was a terrific guy. He died this last year, unfortunately. But he was a great mentor and taught scientific integrity and curiosity. And he had a wonderful lab with multiple NIH grants. He had a basic science laboratory. He also had clinical research in venous thromboembolism, which I was mostly involved with. And that was a great academic start to my career.
And then so you got interested in platelets and
Correct.
Learned what those were, and
Yes.
back early on, and many of your papers have included that. I mean, particularly in the beginning of your career.
Well, this was Ed's primary basic research interest: platelet physiology, and platelet biochemistry. And I became interested in antithrombotic therapy with antiplatelet agents. And that was just beginning. This was in the mid-'70s, and this was just beginning to be recognized as a potential therapy if you could inhibit platelet function. And there were lots of different agents. The simplest one was aspirin, but there were lots of other agents that were under development that we tested in the laboratory and in test tubes, and then in humans too.
So then you came back to the U of M.
I did.
And finished up your general surgery training under a couple of people that were prominent early vascular surgeons.
Yes.
Yeah.
The primary one was Bill Fry.
Sure.
And Bill was chairman of general surgery at the time. He was a vascular surgeon, but he was a fabulous general surgeon also. He did pancreatic surgery, wonderful surgeon, and sort of, we absolutely worshiped the ground that he walked on. And he subsequently went to the University of Texas Southwestern Medical Center, and he left the University of Michigan during my senior year of residency. And he was trying to recruit a number of us, myself, Bruce Gewirtz, and some others, Dickie Dickerman, with him. I had the obligation in the Army, so I went into the Army. And once I finished my obligation in the Army, then I went to Texas to join Bill Fry.
Yeah, and then Bruce Gewirtz did go to Texas, didn't he?
Yes, he did.
Yeah,
Yes,
yeah,
he did.
Yeah, right. Tell us about being in Bethesda and the things that were going on there.
Well, I went to the Walter Reed Army Institute of Research, and it was a bit of a daunting experience. They basically gave you a laboratory, a technician. They had wonderful animal facilities. They had good laboratory support, cell biology, biochemistry support, and that sort of thing. But you basically had to come up with your own project. And so here you were a hard-charging surgical resident, senior resident, and then all of a sudden you're in a research laboratory with a technician, and you think, well, what do I do now? And so there was a PhD physiologist, David Reynolds, who helped us and mentored us. And David was great. He worked with surgeons. He liked surgeons. And we would come up with projects, and there were a number of people that I interfaced with at that time who become great friends subsequently. Hugh Trout was one, he was there. John Harmon, who's a general surgeon now at Hopkins. We formed a great group, and we fed off each other ideas and that sort of thing. And so I started research projects looking at vascular grafts in animals and platelet interactions with the vascular grafts, and that was fairly fruitful. But I missed the clinical activity, and that's where I met Norm Rich. And Norm, another great mentor, Norm invited me to come and be in the vascular clinic one day a week. It was Thursdays, as I recall. And at Walter Reed, it's interesting because they had vascular clinic 5 days a week, basically. And of course, the fellows were, they were great. They loved to have somebody come in and take over the clinic for them. That would free them to operate and do other things.
Yeah.
And for me, it was an opportunity to interact with vascular patients, get involved with the vascular laboratory. One thing led to another, and I subsequently signed on for the vascular fellowship at Walter Reed. And that was a one-year fellowship. But when you do something in the Army, you're obligated for more time. If they do something, you owe them something, correct. And so I had 2 years of service following the vascular fellowship. So I had the 2 years in the lab, 1 year fellowship, and then 2 more years. And I stayed on at Walter Reed and eventually became chief of the vascular service there, which was a great opportunity.
So here you were, pretty young, and
Very
you were
young.
suddenly the chief of the service. How did that all transpire?
Well, Jim Collins was the chief, and Jim decided, I don't know if it was a midlife crisis or what, but he decided he wanted to expand his surgical expertise, and he did a cardiothoracic fellowship. And then the person who was to be the chief of vascular surgery was coming from San Antonio, but unfortunately had a myocardial infarction. And so that left me as the assistant chief, and I was made the, quote, acting chief. And I did that for a year, and I'll never forget my first day on the job. I got a call from the physician at the Senate that one of their congressmen had an acutely ischemic leg. I had 2 new vascular fellows, and I had a president of an Arabian country who was in Walter Reed at the time who was having TIAs, and the neurologists were knocking down the door saying, this guy needs a carotid endarterectomy. So all of this was on my shoulders all at once. Very maturing experience, and it was a great time. It was a fabulous time. So I became chief, and I guess I passed muster. They made me full chief as opposed to the acting chief, and I stayed on for a few years beyond that.
And then what Dr. Rich was at that time?
Norm was enormously helpful. I'm sure he was looking over my shoulder at every turn. But Norm had become the chairman of Department of Surgery at the Uniformed Services University of the Health Sciences, USUS as we called it. And that was a new medical school for the military, new at the time. And Norm was the first chair of the Department of Surgery, and so he had additional responsibilities there.
I see. Very interesting. And then so after that experience, Dr. Fry was able to recruit you to Texas Southwestern.
Yes, I finally decided that as much as I loved my time at Walter Reed, that my future was probably best in academic surgery would be to go to the University of Texas Southwestern Medical Center, which is a great place. And Bill Fry had a robust surgery program there at Parkland and our University Hospital, which was built subsequent to my coming there.
And then you were in charge of vascular surgery there and at Parkland.
Yes,
Yeah,
yes. And we had a vascular fellowship. And Bill made me the chief of vascular surgery. He was chair of surgery, and he entrusted me with the vascular fellowship. And subsequently, he left. And when he left, one of the other vascular surgeons left. Actually, 2 of the other vascular surgeons left, and I was left alone, basically, with the fellow. And so I had to really rebuild from the ground up at Texas, and that was quite a bit of effort, recruiting people and keeping the fellowship going, operating, having private patients, the whole thing, trying to run a research laboratory, which was impossible, but we managed.
Yeah, and you've had some excellent partners.
Oh, yes.
Jim Valentine.
Jim Valentine is now the chief of vascular surgery there since I've retired.
Yeah.
We've had a number of great people.
And then the training program there in general surgery is traditionally the biggest one in the country.
Yes,
Yeah.
correct.
Yeah.
Correct.
And you've worked under a couple of chairmen, Bob Reed.
Jim Carrico. Bob has been a terrific chairperson. And I've served under a number of chairmen in my time, and we've gone through some growing pains, but we've managed. Yeah.
What year did you get to Texas Southwestern?
It was 1983.
1983. So, and then did you start the vascular fellowship there?
No, there was it was an ad hoc. The fellowships were not really ACGM approved at that time. They were sort of ad hoc fellowships, and we had one that was in place, and they were actually applying at the time to the RRC and the ACGME for formal fellowship status. I mean, vascular surgery was applying for that.
Sure.
And we were one of the first vascular fellowships approved.
Right. And that was all where people were given a certificate of special competence.
Correct.
And it was interesting how it all got started.
Yeah, exactly.
Yeah.
We were still sort of under the wing of general surgery, beginning to break free, and it's been an evolution.
So you graduated many fellows. I mean, 20 some odd fellows.
Yeah, 25 or so fellows under my reign. And there are a number of other individuals who were in the general surgery program that subsequently did vascular fellowships elsewhere, and I'm actually as proud of that. We now have places for 3 fellows, but at the time we only had 1 fellow per year. And so we obviously could not accommodate all of our residents, and we liked taking from our own residents. We knew what was a known quantity, so to speak, and they were all excellent surgeons. And so I had to send a number of these general surgery residents to other programs, and they've succeeded equally well, I should say.
And then because of your interest in that area, you got involved with the RRC at some point, and the ACGME.
Eventually, towards the end of my career, I was on the RRC for 6 years, and struggled with the RRC and with the 80-hour work week and some other giant issues of the time, the implementation of the 80-hour work week, which I thought is really not much of a problem for the vascular fellowships.
Yeah, that's
that
true.
was pretty easy because vascular fellowships don't have the same intensity of training that the general surgery residents do. It was a particular problem for the general surgery residencies.
And then the RRC is trying to homogenize all the different training programs as far as the 80-hour work week.
They are. It's one of I think it's a problem because from the RRC's top-down view, they would like to have regimentation, rules and regulations pretty much be the same for all programs. And they do have standardized rules and regulations regarding the 80-hour work week, regarding lots of things. And then there's specialty-specific regulations. The specialty-specific rules and regulations are becoming smaller and smaller and smaller print, and the bold print general regulations of the RRC are becoming more empowered. What that is evolving to is that it's trying to make like one size fits all, like all specialties have the same regulations, and it just doesn't work very well.
Do you think the philosophy is to protect the patients from tired physicians, or to protect the physicians from having to work too hard? What do you think?
I think the initial impetus was to protect patients.
Yeah.
And I think that's that's a real concern, but I think as residents have bought into this, that they like their lifestyle protected also, quite frankly.
Along the way, more recently, you have been working with the American Board of Surgery.
Yes.
And reflect on that some.
Well, that was a particularly difficult and painful time. When I came onto the American Board of Surgery, I was told that you were going to be like the child of divorcing parents.
Oh, yeah.
At that time, vascular surgery and the vascular societies were making a push for an independent board to break away from the American Board of Surgery. But they still had to have a representative from the vascular societies on the American Board of Surgery, and I was that representative. So I was going to the board from the vascular societies who were trying to secede from the American Board of Surgery.
So you were elected from the SVS.
Correct.
As the representative from the SVS.
Exactly. So it was a difficult time because once I got to the board, this was a thorny time for the board also. They did not want vascular surgery to break away from the American Board of Surgery. They wanted to keep the corpus of surgery intact as much as they could. And they made a number of concessions, and I saw this as a window of opportunity for those of us on the board who were vascular surgeons to begin the creation of a board within a board, and that's exactly what evolved. And a lot of credit, and I'm not sure people know this, but a lot of credit goes to Richard Dean, Dick Dean. Dick was on the American Board of Surgery at the time. He was actually a representative from, I think, the Southeastern Surgical Society or one of the other surgical societies. And the board was grappling with this idea of what to do with vascular surgery, because vascular surgery wanted to leave the American Board of Surgery. And Dick and Wally Ritchie, who was the executive director at the time, came up with this concept, well, why don't we try to create a group within the American Board of Surgery that actually looks at the training and certification of vascular surgeons only. And out of that came the vascular surgery sub-board, so to speak. And that eventually evolved in the vascular surgery board of the American Board of Surgery. And that has been, so I saw this as a window of opportunity, that we could make great strides for American vascular surgery within the construct of the American Board of Surgery by having a separate board within the American Board of Surgery. And what it's evolved to is the vascular surgery board has absolute control of everything related to training and certification of vascular surgeons. And that's been a wonderful thing. I mean, it's got us the independent program, the 0-5 construct of training. We can have any construct we want, basically. And for a time, we had the 5+2, the 3+3, the 0-5. So we had a number of training constructs, and it all evolved from this group within the American Board of Surgery that controls our training and certification.
Is that a model that will work for other specialties?
I think so, and I think the American Board of Surgery is moving towards that. I don't know what's current with them now, but I know that surgical oncology is moving in that direction. I think trauma and acute care surgery is also moving in that direction to be a separate group within the American Board of Surgery.
One of the things that Texas Southwestern has been known for is the selected readings. You were involved with those.
Yes.
And I wonder sometimes if that would be good for vascular surgery.
I had that concept too. Bob McClellan, who founded Selected Readings in General Surgery and ran that for, God knows, maybe 40 years or so, absolutely devoted his life to that. And that man was absolutely, and is absolutely amazing. He is just, he has encyclopedic knowledge of surgery.
A scholar of the literature.
He is a total scholar of the surgical literature, and I don't mean just general surgery, vascular surgery, thoracic surgery, you name it. So I saw that what this did for general surgery, and the selected readings was used for a number of years as sort of the word training construct for different programs. And I thought the same thing might be good for vascular surgery. Actually, when I was president of SVS, I floated this idea to Jim Seeger, who was the head of the Education Council, and Jim liked the idea also, and he also had a similar thought. They did a business plan, and when you think about it, the number of vascular fellows that would subscribe to this and the work that would be put into it and the cost.
So it'd be about 100 fellows or something like that.
A little over 100, and maybe some private practice vascular surgeons would subscribe to it also, but it just was probably not sustainable. I still think it's worth thinking about, because you could have a collection of papers starting with historical on a particular topic, say venous disease or SFA disease or aneurysm disease. You could have historical papers that wouldn't change and would introduce trainees to the history of the particular problem or disease process, and then you could have the most current things, and you could have review articles, medical treatment of the disease, and I still think there's possibility there.
Yeah, you might need a certain individual to just take that on as a life project.
Right, exactly. Another Bob McClellan.
That's right. You know, in your career, you took care of all kinds of vascular patients, but you got particularly interested in the infected aortic graft.
Yes.
And
yes,
were very innovative. And how did that all get started?
Well, part of it harks back to Bill Fry. Bill really strongly felt that autogenous replacement of vessels was the best way to go for any kind of vascular reconstruction. And from that, when I was first at Parkland and University of Texas Southwestern Medical Center, we had a number of patients where we were harvesting saphenous veins to reconstruct the aortoiliac system after taking out the infected graft. Bad idea. Did not work very well. They're just too damn small. And they would develop intimal hyperplasia, and a little bit of intimal hyperplasia in a saphenous vein will constrict it and will impede flow, and they eventually went down. They usually went down within about a year. Now, some of that wasn't all bad, because patients would develop collaterals in the meantime, and I had a number of patients that had the saphenous vein reconstructions, particularly if they had occlusive disease. The old graft would go down, and then you could come back and replace it with a prosthetic graft. And some patients say, no, I'll just accept my limited walking and live with it. But then I had a seminal patient who was referred in. She was relatively young, in her 40s. She'd had 2 aortobifemoral bypass grafts, and both of them, well, the first one got infected. It was removed. She had the standard AX-FEM reconstruction, bilateral AX-FEM reconstructions. And they went down, and then she had another aortofemoral graft placed, and that became infected. And when she was sent to me, the word was out around town that we were doing these saphenous vein reconstructions. And so she was sent to me, and she had, I mean, it was like 2 millimeter saphenous veins. They were absolutely tiny. There was no way it was going to work. And my technician, vascular technician, Eva Scoggins, was scanning the leg. She says, "Dr. C," she said, "look at that big blue thing down deep in the thigh. You might think about that." The light bulb sort of went off.
Really?
And yeah, and I remember Marty Schulman. Marty, another interesting story. Marty, here he was a private practice guy from New York who started using the superficial femoral vein for fempop bypasses.
Right.
And presented at the SVS in plenary sessions, and was roundly criticized.
I remember that.
This was another bad time for vascular surgery, and there were defamation suits and all kinds of things. And the vascular world was saying, how could you possibly do this, especially if you've got a saphenous vein? Yeah, you harvest the femoral vein for a fempop bypass, wouldn't you cause all kinds of
leg, right?
Yeah, you'd have all kinds of venous morbidity, and but Marty stood his ground, and his results were pretty good. And the light went off, and I remembered, I actually was at a vascular meeting, and I was sitting behind Marty, and after he presented his paper, and he came back and he sat down, and he had a couple of technicians with him from his, from his practice and that sort of thing, and they were just all slapping each other on the back and that sort of thing. And I thought, that's pretty remarkable for a guy in private practice to come to the SVS and present a paper. And I reasoned that if it could withstand arterial pressure in the SFA position, they could do it in the aortoiliac position also. So that's, the light bulb sort of went off, and the first patient was that particular patient. Matt Rossi was the fellow, and we went to the operating room, and we started doing this procedure, harvesting the veins and then exposing the aortic infected graft, and behold, it worked. And she did great. I mean, 4 days later, we were trying to find her in her room, and she was down on the smoking dock, or she was down on the loading dock smoking. That's where, so
relaxing a little bit.
Yeah, exactly. So, and she did really well, and her legs did not swell, and I mean, we were very nervous about the whole thing, but it worked, and that's where it all got started.
Yeah. What are the principles of that now? What are the limits of how much you can take out?
When you get below the knee, the vein starts branching into tibial branches. It gets very tenuous there. It's a pretty flimsy structure at that point. So the knee joint is pretty much your limitation.
Right.
And you can get a good...
And you leave the profunda branch.
Yes, you absolutely leave the profunda.
Right.
And that, I think, provides collateral outflow, venous outflow, and that protects against the venous morbidity. And we've had remarkable results in terms of absence of venous morbidity. We've had 2 papers looking at the venous physiology before and after, and the clinical results, the legs are not swollen, patients don't wear compression stockings, and they do just fine.
Yeah. And then what's the best way to put together the top part of it when you sew it to the aortic stump?
Just a straightforward end-to-end anastomosis. And
Do you put the 2 pieces together?
Sometimes you can pantaloon them together if the aorta, if the diameter of the aorta is particularly large, that works. But usually you can just, if you take more travel on the aortic side than the venous side, it generally matches up pretty well.
So you just use one piece of SFV into the aorta.
Exactly. And the proximal portion of the SFV is larger in diameter than the distal. So you have to put it in a non-reversed position. And one of the things I learned was that we initially ablated the valves with a valvulotome, which doesn't really work very well because we got some venous stenoses and we had a couple of acute thromboses, and I everted the vein and looked at it, and it's a huge vein, obviously, and the valves are big, and the valvulotome would make a little nick in the valve, and that was about it.
Yeah.
So I finally got to the point for the last 6 or 7 years, I've been everting the vein and actually excising each valve.
Take the scissors and take the valve out.
Exactly. Okay. So you have to use the proximal portion to sew to the aorta because that's the largest end, and that's about a centimeter, centimeter and a half in diameter. and it'll approximate a normal aorta pretty comfortably. A bigger aorta, then pantallooning, there's some other techniques you can use to make it comfortably fit.
And then you just sew the other side on as a side for the other iliac.
Exactly.
Yeah.
All right. And the side.
Yeah. Besides that, what other operations were your favorites?
I loved carotid endarterectomy, and I'm glad to see that it's still a viable procedure in the face of angioplasty and stenting, and is actually preferred. That's one of the other areas that I've been interested in also.
What have you done besides, what sort of hobbies do you have? You're interested in music, I know.
I'm interested in music. I play classical guitar and composed music for classical guitar. None of it's published, but I do have a website.
Do you really?
Yeah, I have a number of pieces of music on the website, which is free for anybody to use. I'm not sure anybody's used it, but it's out there.
Oh, yeah.
And so I enjoy doing that.
Do you practice?
I do. I practice when I was active. Practice time was really limited. Maybe a half an hour to 45 minutes a day. But if you're composing music, you can't practice at the same time because the composition takes up your time. If you're playing music, then you practice for long periods of time and get pieces mastered and that sort of thing.
When did you start with the guitar? At what age did you start?
I started in my, I guess my late 20s when I went to mid-20s. During surgical residency, actually.
So you've been doing it for quite a while.
Yeah,
That's good.
Yeah.
But you didn't start as a child.
No.
Yeah.
No.
Yeah. All right. And then you like to row.
Oh, I love to row.
Oh, yeah.
Sculling is a great activity. My wife and I do it together. We have 3 shells. We have 4 shells. We have 4 shells. We've got a double and 3 singles, and we keep them at our cottage up north on a little lake up there. We row in the summertime.
Which lake is that?
Little Platte Lake in northern Michigan.
Oh yeah, very nice.
Yeah.
But you don't race.
No, I don't race. When I was in Dallas, I joined a group of other. There were 2 doctors and some other businessmen, older people who were in a quad. And we worked out for a while together, but I didn't have time to really condition myself and get into the racing thing. So I never did that. I mean, as a busy surgeon, you really don't have time to these people, I mean, they travel all over the place to compete, and I didn't have time to do that.
Yeah, that's for sure. One of the most important clinical trials in the last 20 or 30 years was the NASCET trial, and you ended up being an important part of that.
Yes, that was, I was an advocate of joining the NASCET study. There was another area of controversy in vascular surgery, obviously. The vascular surgery community was pretty much made up its mind that carotid endarterectomy was appropriate for symptomatic patients with carotid disease and did not want to join a randomized clinical trial. So I think the vascular surgery community was against it. But at my institution, which was dominated by conservative internists and neurologists. This was UT Southwestern. At the time, they've since changed their ways, but at the time, a patient could come to the ER with a screaming bruit, having crescendo TIAs, and they would be sent away on aspirin. Oh, yeah. And that was the treatment.
Yeah.
And then they come back stroked, and they, surprise, surprise. But the neurologists were adamant. They said, well, even despite that, that's less dangerous than subjecting a patient to a carotid endarterectomy. So at my institution, the medical treatment was pretty much the preferred treatment if those people got to the patient first. So my reasoning is that we really had to prove this operation to be effective, and I also thought it was important nationally also because there was a giant criticism from the neurology community, from conservative internists, that carotid endarterectomy was being overdone, and it probably was at the time, but it really needed to be proved by a randomized clinical trial. So I thought the NASCET was actually a great opportunity to do this.
And then that involved randomizing patients even with a 90% stenosis who were symptomatic.
Oh, I remember one of my first patients, and I had a research coordinator. She came back with tears in her eyes and she said, I just randomized a patient from the VA that has bilateral 80% stenosis and is having bihemispheric TIAs fairly frequently.
Right.
He had amaurosis in one eye and he had cortical symptoms on the other side. And he was randomized to aspirin or medical treatment. And surprise, surprise, he actually did very well. He stopped having TIAs and he died of prostate cancer 3 years later and he never had a stroke. So there you are.
But that was one of the reasons that it was hard to get people to participate in the study, wasn't it? Because you had to randomize patients who had tight stenoses who were symptomatic.
Exactly. But that was one of the important findings of the studies, that there's a gradient. The tighter the stenosis in the symptomatic patient, the more likely there would be of stroke and the more likely there would be a failure of medical treatment. And so the NASA was a terribly important study.
Right.
And Henry Barnett, who was a so-called enemy of the vascular surgery community because he launched the trial, actually turned out to be a bit of a hero.
And then you ended up being involved with the analysis of some of the data too, didn't you?
Oh yeah, sure. Yeah.
What group was doing that? Henry Barnett was the chairman of it.
He was the lead investigator, and I was on the executive committee. And the reason that I became on the executive committee and allied with the leadership of the group is because I persuaded a number of centers in the United States to become members of the NASA group, and using the same reasoning that we've got to prove this operation is effective, and we know it's effective inherently. We've had lots of anecdotal experience, but it really, there is equipoise and it needs to be proved in a randomized clinical trial. And so I got a number of centers entered into the NASIT group from the US, and ultimately the NASIT group recruited centers from around the world. It was not just North America, but there were centers in Europe. And that was because we were having trouble meeting our accrual rates. And the NIH, if you don't get your patients accrued in the study, we're always afraid of the funding being pulled. And so we got a number of patients, and the initial results were really striking. Not surprising, but really striking in favor of endarterectomy.
And then the study was stopped.
Right.
Yeah.
It was stopped.
Remarkably. Right.
2 years into the study.
Right. Very interesting. One of the issues in training vascular surgeons is that with the endovascular, it's hard to teach them the open techniques because there aren't as many. Do you have any advice for us?
I don't have a good answer for that one. I think that robust programs that do a lot of endovascular work should keep their eye on the ball of the open procedures also. I'm very concerned because I see, when my time on the RRC, looking at the numbers of, say, open aortic aneurysm repair, they're just really going down dramatically with EVAR. And yet that is an operation that you have to perform every now and then. So I'm concerned. I don't have a ready answer. Maybe simulation will be helpful and help people get their open skills up to snuff, but there's nothing like the real world of doing it. I have to say that, and I look back on my own training. Training is a lifetime experience. It's not just your training for your period of time in vascular fellowship. When I finished my vascular fellowship, I had 79 cases. I wouldn't pass the RRC right now. I wouldn't get the minimum numbers. And at that time, vascular fellowship, there were no minimum numbers. This was early in the game. But when I finished my vascular fellowship, 79 cases, most of them were carotid endarterectomy, very little visceral reconstructions. I think we maybe did 1 or 2 infected aortic grafts during that period of time. But again, your training is a lifetime evolution. You train continually in your practice as a practicing vascular surgeon after fellowship. So I learned a tremendous amount subsequent to my fellowship and learned more. So you can get the technical skills later on.
Do you have anything else you'd like to reflect on?
When I was president of SVS, at that time, it was approximately 5 years after the merger of the two vascular societies.
Right.
And we really were trying to keep the ball rolling as one unified SVS, Society for Vascular Surgery, group. And I think there was an issue with identity among the vascular surgeons at large, and was this the old SVS, the old snobby academic community, or was this really a new, more grassroots organization? And I felt strongly that we should be a grassroots organization, and we should incorporate as many vascular surgeons into the SVS as possible.
Be inclusive.
Be very inclusive. And there was argument on the executive group about how exclusive we should be versus inclusive. I was way to the left. I wanted anybody that did vascular surgery, I thought should be a member. Well, we sort of ended up middle ground. But we did create a number of slots for individuals. We also launched a membership drive, and I was talking to Becky Marin this morning, and from what we did, we went to regional and sub-regional vascular societies and got their membership list, and people, and crossed them, indexed them with our own list, and people who were not members of the SVS, we reached out to in email and mailings. And that's been very productive. We've gone from, when I was president, I think there was approximately 2,000. Becky says this morning there's like 3,600 members. So we've grown dramatically, and I take a little credit for that. Also, when I was president, I put together the vascular PA group. We have a vascular nurse organization, but I think that they haven't been particularly robust. The vascular PAs and the nurse practitioners, I think, are really important to our specialty and other specialties.
And it's definitely up and coming. I mean,
oh, definitely.
There are only going to be more of them, and they're
absolutely
they're mostly excellent.
So they have their own group now, and I take credit for that. They're actually presenting papers and having their own meeting this morning. The other thing that, a couple other things that when I was in office that we did, we developed the Document Oversight Committee. When I became president, it was amazing the number of documents that were being put out with the SVS logo, but there was no central controlling group that was looking at these documents critically. And there were, some of the documents were, they came out of committees and the Clinical Practice Council and some other councils, and there was no timeline about when the documents would be initiated and finished. And so we were trying to get these documents out, but they were just not coming together. So we put together the Document Oversight Committee, which is a group of senior individuals to oversee the initiation of SVS documents, to keep people on a timeline. So if you're going to write a document, you're going to make a promise that you and your group are going to get this done by a certain date. And if you don't, you're going to you're going to have Wayne Johnston and his group breathing down your neck. And then once the document's completed, then it goes to this group who critically looks at it and says, do we want SVS's name on this document? And then it goes out to the standard editorial review process. So that's been a good thing. And when I became president, there was something like 20-some documents that were out there floating around with no rain on them. And we've gotten those documents under control. The other thing that I did when I was president, I thought we really needed to define our relationship with industry. That's becoming under increasing scrutiny in recent years. And I thought SVS should be out front. And so we put together the conflict of interest guidelines and also appointed a conflict of interest committee that oversees all of the relationships with industries, from individual members of committees to the board of directors to the executive committee. That committee looks into all kinds of potential issues related to conflict of interest. And that's been a good thing.
One idea that you had that you talked about in your speech as president was the comparative effectiveness of treatment, looking at cost and effectiveness. How are we doing with that, do you think?
Not as well as we probably should be.
I know it's a tough one, isn't it?
It's very tough.
Yeah.
And I think that comparative effectiveness really gets at issues of cost. Scientifically, it's supposed to be a separate sort of discipline, but in the final analysis, it really is looking at effectiveness and the cost of effectiveness, so cost effectiveness. And I think that we are becoming ideally positioned to really look at this more in depth with our vascular registry that's being developed with multiple vascular practices donating their data to it, into it. So I think this is an evolving thing, and I think it's going to become really important because I think the screws are going to be ratcheted down from government in terms of what reimbursement is. So we're going to have to figure out ways to do effective things cheaper.
Right. Thank you very much for being part of this.
Thank you
for talking about all these important things that have occurred during your career.